thanks to the Torrent company for organizing this, and thanks, dear friends. It's a pleasure to see you this morning. Now, cardioembolic strokes come because of a clot in the heart, and it's a kind of a devil. Now, why do we call it a devil? Ischemic stroke, unlike a myocardial infarction, comes from many mechanisms. And as you can see, it can come from the heart. The clot can travel from the heart to the brain. It can come from the aorta. It can come from the carotid artery, stenosis. It can come from the intracranial. It can be a small occlusion in these penetrating vessels. So there are 5 mechanisms because of which a stroke can occur. And we have to identify the mechanism. But out of all these mechanisms, cardioembolic is very important because almost 25% of all strokes occur because of a clot which actually forms in the heart. Therefore, it's the devil of all the mechanisms. And it's also a devil because the cardiac clots are bigger. They are platelet rich, they are RBC rich, they are fibrin rich compared to the clots which form in the carotids. Carotids are they are mainly platelets, but there is not so much of fibrin in it. So therefore, these clots which form in carotids or arteries, they are also called white clots, whereas the cardiac clots are called red clots because they are heavy. They are just like bombs, like missiles, which come out of the heart and go to occlude the arteries in the brain. And because they are big clots, therefore they block the large arteries like this main artery, middle cerebral artery, and cause the occlusion of this main artery, unlike these small arteries which you can see here. These small arteries. These are the lacunar strokes. But cardiac clots are big. They block the main arteries. Therefore, they can cause aphasia, hemianopia, all the cortical deficits in addition to hemiplegia. You can see this is a typical cardioembolic stroke which has involved the entire MCA territory. And just compare it with a small penetrating infarct, how small it is. So first thing we should remember is that cardioembolic strokes are usually, but not always, bigger strokes. And the other thing which happens in cardioembolic strokes is that they recanalize. You can see this is a cardioembolic stroke. MCA is blocked here, but within 24 hours, it recanalizes. Now, that may not be a good thing, because once it recanalizes, suddenly floodgates are opened in an area which has been damaged by ischemia. Ischemic arteries are very fragile, and in those fragile vasculature, once the floodgates of blood are opened, it causes hemorrhage. As you can see from this pathological specimen, the pale area is infarct, and within that infarct there is a bleeding, which has happened because of reperfusion. Now, why this reperfusion happens? Because cardiac clots are soft. They are not attached to the vessels. They just go, block, and they get lysed. And that causes actually hemorrhage into the tissue. So therefore, cardiac clots and cardiac infarcts are more prone to hemorrhagic transformation. That's another reason why cardioembolic strokes are dangerous compared to other strokes. And the most important thing, another thing is why it is more dangerous compared to other strokes is it has got a high chance of recurrence. You can see a clot here, and this clot, with each beat of the heart, it is moving that clot. With each beat of the heart, it's moving that clot. So therefore, there is a high chance of recurrence. It will keep on happening again and again and again, unless we take measures to stop it. So because of these 3 reasons, the cardioembolic stroke is called a devil. But you may not always see this cardioembolic clot. It can be very fleeting. Many times in a heart also, when you do echo, you don't see the clot because it has already left, it has already gone, and sometimes the clot becomes small even for the 2D echo to pick it up. But it is big enough to block the artery. And as I showed you just now, that sometimes the clot in the brain also dissolves spontaneously. So therefore, a lot of times there is a clot in the heart, it goes to the brain, it causes the damage, and then it disappears. It disappears from the heart also, it disappears from the brain also. Therefore, many times cardioembolic strokes are called smoking gun phenomena, where you are seeing a gun, you are seeing the smoke coming out of it, and you assume that the bullet must have come. Bullet in this case is a clot. You actually don't see the real bullet. You only see smoke coming out of the gun, and you assume this must be a cardiac. And the smoke in gun here, in this case, would be detection of a cardioembolic source rather than seeing the clot itself. So these are the criteria for making a diagnosis of cardioembolic stroke. First of all, some clinical and radiological features by which we can make a guess that this might be a cardioembolic stroke. Second is that you see the potential cardiac source of embolism. You need not see the clot itself, but you see the source of the embolism. And third is that you exclude other potential sources of cerebral ischemia, like carotid stenosis and all. So if you see this, you are reasonably sure that you are dealing with a cardioembolic stroke. Now, these are the clues on history which may give you an idea that this may be a cardioembolic stroke. Number one is that they have abrupt onset and maximum severity at the onset. Unlike a carotid artery, which may be stuttering, which may progress over the course of 2 hours, 4 hours, or even 24 hours. But cardioembolic stroke is sudden and it is maximum severity. Sometimes they rapidly recover because the clot dissolves, but many times they don't recover. Then, as I said, they are big strokes, so therefore they will have aphasia, hemianopia, neglect, in addition to the hemiparesis. And because they may have, because it's coming from the heart, it may involve various territories. Means today he has got left hemiplegia, but he may give a history that 5 months ago there was a right hemiplegia. 6 months ago there was some other deficit. So if there's a story of involving different territories, you always think maybe there is an underlying cardiac source. And of course, the most important thing is that in a stroke patient, if there is a history of any kind of a cardiac disease, think of a cardioembolic source. Means if the patient has undergone a bypass surgery before, or if there is a history of atrial fibrillation, or even if there is a history of ischemic heart disease or rheumatic heart disease, then the first chance is that most likely this fellow is having a cardiac clot which has traveled to the brain. And on physical examination, if there's an irregular pulse with frequent pauses, suspect atrial fibrillation or arrhythmia. Always we should check in every stroke patient, look for murmurs. This is another clue that there may be a cardioembolic source. Signs of congestive heart failure. History of myocardial infarction. Recent myocardial infarction is a high pointer that this patient is having a mural thrombus which has gone to brain. But even remote myocardial infarction also is a source of clot sometimes. So therefore, all these things, if you have any clue to the cardiac disease, it should alert us to the possibility of a cardioembolic stroke. Now, on radiology, as I said, typically, if you do their scans within first 24 hours, you will see a big infarct. As you can see, this is a patient of rheumatic heart disease, and you can see the whole vessel on this side is blocked. And this is another example that this is a patient who has come with an acute stroke. This is a diffusion MRI. But on the MRI, you see there is a history of, there's evidence of old stroke also in a different territory. So this is also one signature of cardioembolic stroke. That means strokes in different territories during different phases of time, and sometimes they can be during the same event. This is another patient who has come with a hemiplegia. You can see there is an infarct on this side, but incidentally you see an infarct on the other side also. Now this cannot happen in carotid artery disease or MCA. This can happen only if the clot is coming from a proximal source like a heart. So therefore different territorial involvement during this episode or during previous episodes is also a pointer towards a cardioembolic stroke. This is one of our own patients who came with a fever, and along with that there was a deficit, and on scan we saw that there was an infarct on both sides, and we did his echo and we found that there was a vegetation there. So this was a patient of infective endocarditis who presented with stroke, and he had an underlying bicuspid aortic valve. So we must remember this. So therefore, any patient who has any underlying cardiac disease with these kind of clinical features, we should consider cardioembolic source. Now these are the diagnostic tools to pick up or confirm the cardioembolic source. One is routine EKG, 2D echo, transesophageal echocardiography, Holter and loop recorder. I'll go through them quickly. Now this is an example of a ECG in a patient of atrial fibrillation. Now you see, if you look at it very grossly, you may not even pick up atrial fibrillation. In fact, when we saw his pulse, it looked quite regular. But if you carefully look at ECG, there's hardly any P wave there. So therefore, ECG is still very important. We must look at the ECG to look for atrial fibrillation. And another example of a patient who came with acute stroke and the routine ECG showed a acute myocardial infarction. Sometimes the myocardial infarction can be silent, and acute myocardial infarction is a very important source which we should not miss of a stroke because they develop mural thrombus. So ECG can give us a clue towards the cardioembolic source, as in this patient. Similarly, this is one of our patients who has tachybradyarrhythmia or a sick sinus syndrome. In fact, initially when she came with a stroke, we did not know what was the cause. She used to have episodes of vertigo, and during one of the episodes of vertigo, the ECG showed a sick sinus syndrome. So ECG is very important. You may detect on ECG itself the cardioembolic source, but sometimes ECG may not pick it up, so therefore 2D echo also should be done in all patients of stroke, and all these conditions will be detected by 2D echo, which is an excellent investigation. It's non-invasive, it's everywhere available. So what you will detect by 2D echo is mitral stenosis, prosthetic heart valve, myocardial infarction, in the past 4 weeks showing akinetic segments, mural thrombus, left ventricular aneurysm, regional akinesia, ejection fraction, less than 30%, left atrial thrombus, dilated cardiomyopathy, endocarditis, and sometimes intracardiac masses. So therefore 2D echo should be done in all ischemic strokes, and just the presence of it is enough to say that this stroke is cardioembolic. You need not see the clot itself. If you find this, this is good enough. Now, suppose you don't find anything on the 2D echo, then you should go for transesophageal echocardiography. It's invasive, it's like an endoscope. You have to go through the esophagus, but it gives a much better assessment of the heart. These things can be picked up sometimes by TEE, which 2D echo can miss, like mitral valve vegetation, like atrial myxoma, atrial appendage thrombus, patent foramen ovale, and aortic arch atheroma, which is also an important source of embolism. In the arch gets atherosclerotic, it gets mobile thrombi which can dislodge. This is an example of a left atrial appendage thrombus, this big thrombus picked up by transesophageal echocardiography. Now these days there's a concept of embolic stroke of unknown source. Means you know that there's a stroke patient, he comes with the abrupt onset, but you don't find out a cause or a source anywhere. This has been called embolic stroke of unknown source. It's also called ESUS. And the three most important causes which have been found in these are aortic arch atheroma, patent foramen ovale, and paroxysmal atrial fibrillation, which means routinely you will not pick up AF, but sometimes you will find it 1 minute or 2 minute or 3 minute episode of atrial fibrillation. So during that time, they throw the emboli. And paroxysmal atrial fibrillation is as dangerous as the persistent atrial fibrillation. This is an example of the aortic plaque in a TEE. You can see this when it's more than 4 millimeters. It is a very high risk embolic source. This is an example of patent foramen ovale. If there's a patent foramen ovale in a person less than 55, and if there's an associated atrial septal aneurysm, then this is also a high risk for a cardioembolic stroke. And another very interesting thing which is picked up on transesophageal echocardiography is called spontaneous echo contrast, which means when you do the echo, you find that there is some haziness, something like a smoke in the left atrium, and this itself is a thrombogenic source, usually found in patients of atrial fibrillation or mitral stenosis. But the presence of this smoke is an indicator, it's a surrogate marker of the clot. So therefore TEE is very important investigation which picks up a lot of cardioembolic sources which can be missed otherwise. And as I said, paroxysmal atrial fibrillation happens very, episodically, and sometimes just a routine ECG does not pick it up, so we have to do prolonged Holter monitoring. So in patients of ischemic stroke where you don't find any cause, always look for the heart. Usually 24 hours of Holter monitoring is routinely done, but sometimes it may have to be done for 1 week. And these days, there are loop recorders which are attached to the patient's body, and they are kept up to as long as 3 months or even 6 months. And then you analyze the recordings, and many times you find there's a paroxysmal atrial fibrillation. And paroxysmal atrial fibrillation is as dangerous as routine atrial fibrillation, and they have also to be anticoagulated. So in summary, what I would say is that cardioembolic stroke forms about 1/4 of all ischemic strokes. These are recognized by being big strokes with aphasia, hemi-neglect, hemianopia, but sometimes in 5 to 6% they can cause small strokes also. But usually they cause big strokes. The common causes are mitral stenosis of rheumatic heart disease etiology in India, but also now non-valvular atrial fibrillation. But there are also other causes which I told you, like aortic atheroma, or like patent foramen ovale, or paroxysmal atrial fibrillation, which we have to look for them, we have to search them, only then we will get it. And the tools are ECG, 2D echo, TEE, and Holter. With the judicious use of all of them, we are able to detect the cardioembolic source. I want to end my talk. This is my favorite, Willie Sutton. He was an American bank robber, and in his whole life he has committed about 30 bank robberies, and they could never catch him. And finally he was caught. But the thing about him is that he always robbed banks. He never robbed churches or schools or buildings. He was a bank robber. So then in the court they asked him, Willie, why have you always robbed banks? He said, because that is where the money is. So in a stroke also, always look at the heart when you don't find any clot, because that is where the clot is if you don't find the clot anywhere else. Thank you very much.